Hello everyone. Let me please introduce the title of my PhD work, Novel Digital Health Approaches in Oncology. I'm Seba Aljomaa. I'm a pharmacist from Syria under the supervision of Dr. Miklos Garami and my SMS Mark. We are working on two parallel projects, starting with the first one. Let me please introduce it. Comparing the effect of digital health interventions on the quality of life of individuals facing cancer by conducting a systematic review and meta-analysis. Because of the impact of cancer on patients' quality of life, these percentages can show clearly anxiety, pain, and fatigue, all these overload among cancer patients. Unfortunately, till now, the current standards of care are not enough to decrease this suffering. Thinking out of the box, looking on the adaptation of technology nowadays. Also, we have, on the other hand, COVID-19 pandemic, where using such interventions accelerated. So even WHO started to publish recommendations on how to use such interventions in healthcare. So we think that digital health interventions could be good tools to improve the quality of life of the patients, so we aim to investigate the efficacy of these interventions in oncological care. We ask the question, does the electronic health, so e-health, and the mobile health, m-health interventions, change the mental and physical health outcomes of cancer patients during their therapy? So we compared different digital health interventions with all the possible types, and the comparator is the standard of care in the hospitals in general to measure the mental and physical health outcomes of these examples, but the criteria is to use the standardized scales to measure such outcomes. And our hypothesis that digital health interventions will improve the mental and physical health outcomes of these patients. And we conducted this systematic search with 3 domains search key, starting with about 25,000 articles, ended up with about 200 eligible ones to be analyzed. So to make it easier, we tried to make categories of the possible data we have and ended up with these 4 ones: games, virtual reality interventions, mobile applications, and web-based interventions with different methodology of each one. And today I will present 4 plots to represent each one of these categories. Starting with the games, quality of life change differences between gaming intervention in the experimental groups and the controls of standard of care. So here we see that the results are on the right side of the plot with the SMD as the tool, which is the appropriate one in such cases because we have a very heterogeneous publications regarding to the methodology and the criteria. So the SMD can represent this variety. And the result is 0.69, which is moderate comparing to the SMD range. The result is not yet significant, and the heterogeneity is 27% because of the heterogeneous methodologies. And now let me please show the second plot about the virtual reality category, where the anxiety change differ from the intervention groups comparing to the standard of care groups. And here we use the subset because the virtual reality interventions were designed at some way based off the treatment type. So we have different treatment subsets, and the result also by using the SMD is supporting our hypothesis about decreasing the anxiety at some way, so it's clinically relevant, but not yet significant mathematically. And also the heterogeneous is very high in each subset, if you can notice, about 90% in each one. Now the third plot is about the mobile app interventions, and here the quality of life change differences between such experimental groups and the controls of standard of care as well. Using the SMD, the result is 0.36, which is significant, and the heterogeneity here is about 10% on the right side of the plot. And finally, the final plot is the quality of life change differences between web-based interventions and control groups of standard of care. The result here also very heterogeneous, so it's 0.18 about the SMD and not significant with heterogeneity of 68%. On this project, now we are working on risk of bias and degrading in parallel. Actually, we have finalized 50% of it and looking forward to go further also to start with the manuscript. But the strength here that we have many RCTs. Also, many tools have been developed in this field. On the other hand, many publications or studies use the interviews or semi-interviews to measure the outcomes. It's very hard also to compare the studies to each other, so it was complicated actually because of different cancer type, age groups, and even the interventions themselves was not on one page. Also, mostly the sample size was small here. But we concluded that digital health interventions improve cancer patients' quality of life, and the virtual reality has the potential to reduce their anxiety. We are looking for age-specific digital health interventions to be introduced to the oncological care. And also, we are looking for more RCTs with homogeneous populations and new age and disease-targeted interventions to be developed. And now I will introduce my second project on the same field, investigating the distracting effect of tablets, virtual reality, and analgesic cream during regular pricking of childhood cancer patients. And here we are looking to conduct an RCT. Actually, the children with cancer are suffering, not just because of the cancer and the treatment, but also because such pricking, which is a painful procedure, I would say it's the most common intervention to be at least once a week delivered to the patients. This needle procedure causes pain, fear, and distress in children. Unfortunately, till now, we can relieve the pain by using the conventional methods like lidocaine cream, but it takes time. And also, we have limited sources like iPads and VR glasses. But still, the virtual reality glasses are a novel immersive technology with the capacity to distract the children's minds about thinking and focus about thinking and focusing on the pain. So we aim to define the most effective distracting technique to reduce pain and anxiety of children cancer patients during their regular pricking. So what is the most effective tool? Basically, we are comparing the first arm, tablets like iPads during the pricking, to the virtual reality glasses as the second arm, and the comparator is the standard of care in our clinic, which is lidocaine, prilocaine, local cream, or patch, used 1 hour before the procedure. We are measuring pain by visual analog scale, and anxiety by multidimensional anxiety scale for children, MASC-10, which is validated into Hungarian, and also the satisfaction by 4 Likert scale, and all these results are patient-reported ones. Our hypothesis that the use of the virtual reality glasses is the most effective to reduce the pain and anxiety of childhood cancer patients undergoing such painful procedure. And we are looking for the implication on the level of clinicians to reduce the pain and anxiety in the childhood cancer patients, and also on the level of policy making to reduce the harm in healthcare. All in all, I would say that through these two projects, we are looking for improving the quality of life of the cancer patients, and especially the children during such distress cases like using needle procedure. We hope that we can do something to improve this, and at the end, I would like to finish my speech by Carl Sagan when he said, "Somewhere, something incredible is waiting to be known." Thank you so much.
While we are waiting for the questions from the audience, congratulations. So I have one question. I guess the content what the children watch on the iPad or in the VR glasses matters. How you choose the right content?
Okay, thank you for your question. Actually, in this regard, we are working with a Hungarian company called Oncology. which is also or has a collaboration with Semmelweis to give us the content of the virtual reality videos. The point that we decided to let the patients to choose, the children, because we have like a lot of available, even commercially and free videos on YouTube. You can watch it. It should be compatible with the headset we are using, but actually they can use like going to the jungle or maybe in the ocean, like a journey, or this kind of even sometimes like to Disneyland journey. So we decided to choose like 2 or 3 options of these. Compatible as well with the videos we're gonna show on the iPad. So it should be the same content with the same music, plus that the headset is the same in both cases, but the difference that since VR is an immersive technique, so they need also the glasses to be isolated from the environment where they are.
I have one question, Seba. Excellent presentation. What I was missing to emphasize the follow-up time of these interventions, because I saw like in your first plots you included the follow-up time. It was different, sometimes 3 weeks, 3 months, 12 months. And actually on one of your plots, 12 months wasn't actually, it didn't change much. Within 3 months, we had much better improvement compared to 12 months. So did you consider making time dependency analysis, for example, to check if the time actually play a role?
Thank you for your question. Actually, I think you are talking about the last 2 categories, because we have very different time points regarding to the mobile applications and web-based interventions, since the patient can use it at home. So the follow-up can vary and be like, as you said, months. Actually, now we are still waiting for more analysis in these 2 final categories. And because in the studies, mostly, they used 3 at the baseline and many time points in the middle, like can be, for example, after 2 weeks, 1 month, 3 months, 6 months, 1 year, so it depends. We try to make it like something in between, which is when really the use of this intervention have been finished. So if it finished after 1 month or for 2 months, let's say 3 weeks, so it's more similar. But at the end of the day, we cannot define an exact timeline of these, especially these interventions, because it's easy to use. While the virtual reality is in the hospital, the gaming also was watched more carefully because of the fatigue of the cancer patients. So they got more freedom, I guess, in these categories. So thanks for your note.
Thank you, Seba. Any more questions?
Congratulations for the presentation. I would like to ask that you had some outliers in the first project. Do you know that did they use different content than the others, or was it better, more feasible, things like that?
Thank you for your question. Actually, I always struggled with these studies, but actually I cannot say that it's an outlier, but we try to justify what happened. And the reason mostly was because of the cancer type and the age range. And I can show you an example in the mobile applications, I guess. No, sorry, here. In the web-based interventions, this Wang study, actually here the patients were with lung cancer, while all the other studies used mixed types of cancer. And even in this study, the criteria were more strict. So for example, they were initially diagnosed during the first 3 months of treatment. Also, they were getting just chemotherapy, no any other type, like sometimes there is concrete radio and chemotherapy, no, just chemotherapy. And also their performance grade was 0 or 1. So they are in a good physical health, I would say. So this is the reason, I guess, to get better result, because they were more oriented to a specific group of patients. But in other studies, on most of the studies, there is no such a criteria. Maybe because it's a new developed technique, so they're still like at the level of preliminary effect. If it will be well, maybe they will go further for more specific studies. So actually, this is what we were able to get from the studies, or how to interpret our result.
And in the other studies, were there any subgroupings that these cancer types are better, worse?
Actually, the age range also was a factor. It could be responsible, because in the virtual reality, during the painful procedure, the patients with higher, or I would say older patients, were maybe more able to control their anxiety than the children between 10 to 12 years. And also in some cases, there were patients, let's say adolescent, maybe they are more into like using the technology than the very little children of 10 years. So till now, this is what we got, but in general, there is no like a very sharp or clear difference between the studies. We are trying just to interpret based on these differences.